Arnon Bentovim is a consultant, child and family psychiatrist. He is a world leader in both the assessment and treatment of child abuse, child neglect, the families where these terrible circumstances occur, and training of services to address these problems. We've been so lucky to be able to talk with Arnon to describe his career, the way services for child abuse have developed over the years, and what he's doing now to try and promote high quality assessment and intervention to help the victims of child abuse and neglect and to help the families that are suffering from these problems. Arnon, it's lovely to talk to you again. And as I was saying just a moment ago, what would be particularly nice for us would be to understand something about how things developed over the years and what the situation was when you first came into the child protection work earlier on, years ago. Tell us how you were introduced to it and how things have developed
Ye-
since then.
Yes, thank you. It's very nice to have the opportunity of thinking and talking about. There's nothing we old guys like
Yeah,
talking about talking
yeah,
about our story, and of
yeah.
course, so really the story spans. I got into the field of child protection in the 1960s when I was a newly appointed consultant at Great Ormond Street, and people had become aware of the epoch-making paper by Henry Kemp, The Battered Child Syndrome. And of
Mm.
course, this sent shockwaves through the whole pediatric establishment. And so I was asked, as the newly appointed boy, as it were, would I uh, set up a task group to look
Can I
at it?
interrupt you right away? Before that, what was happening with children who turned up with injuries? Because
Well, well, it's interesting you asked that because one of the things we did with this workforce of ours, which included the neurosurgeon Kenneth Till, very distinguished neurosurgeon, was that he undertook to look at the records of all the head injury cases, serious skull fractures, which had been admitted to the hospital of children and young people. And of course, what he found when he went through the records was no explanation given, couldn't understand how this might have happened. How on earth could he have fallen from the cot? It just seemed he was so well protected, but he did. And so, what actually happened was that the explanations, the rationalizations given by parents about why their children had suffered severe head injuries was just accepted. The children went home again. Goodness
mm,
knows what happened on follow up. But it was after the publication of the Battered Child Syndrome that we set up a group in the hospital and said that every child who was admitted with an injury, where there was a referral with an injury, we would carry out a comprehensive assessment because we would, in other words, following Henry Kemp's ideas that the battered child syndrome, fractures, bruising, particularly sequence of fractures and bruising, were associated with maltreatment. And we
mm,
really began to say we have to consider this with every child who was injured. And of course, we then began the whole process of linking with social services departments, of course, who were concerned with welfare rather than abuse and neglect. And we began to try educationally to draw attention to the concerns that Henry Kemp had drawn attention to. And of course, he had this sequence of concerns that he expressed in a very well known address that he gave to the International Association for Child Abuse and Neglect, which was established. And in the 70s, he talked about the sequence of recognition of different forms of maltreatment. First of all, the severely abused, battered child with serious injuries, and then very serious neglect of children with failure to thrive, poor growth, um, and then beginning to look at the issues of the emotional abuse of children, children who were rejected, scapegoated, um, and then concerns about children in residential contexts who were neglected. So
was he talking about the emotional side right from the beginning,
yes.
or was the focus on the physical injuries?
No, he worked very closely with other colleagues, with Ray Helfer, another paediatrician, and also with mental health specialists. And they began from the early days to think about the mental health issues of parents, factors that led to the harm to children, factors which meant that parents began to see children's distress and unhappiness as defiance and deserving of punishment. And so from the beginning, there was very much a focus on the mental health issue. And they really established an interdisciplinary, multidisciplinary team from the beginning in Denver, in the Children's Hospital there. And that's been the tradition which they established and which has continued. They published a book, The Battered Child, back in the with a very famous purple cover with a rag doll on the front, which was really everyone's Bible, and that described.
Was that the Kemp Centre, Arnon?
Yes,
in Denver?
yes.
Right.
It became the Kemp Centre.
It became the Kemp, yes.
But when Henry was working there, it was the Children's Hospital in Denver, and that's continued to be a core centre for research and concern. So Henry described these, and then of course what came in the middle 70s was the concern about sexual abuse and the awareness. And I remember being in the States and seeing television programs in the 70s when I'd been there for conferences with people talking about sexual abuse. And I said, my God, that can't happen. That doesn't happen here. And then subsequently, I was approached by Pat Beasley Mrazek, who was in the UK she came on a sabbatical with her husband David Mrazek, and she said to me, "Look, Arnon, I'd like to ask paediatricians, social workers, because by then we'd already established the idea of an interdisciplinary way of trying to understand, and case conferences began to be established, and really a multidisciplinary approach." And she said, "Arnon, people know you, so would you mind sending out questionnaires to people? They'll respond to you, but they won't to me." And so we did this first survey of the presence of sexual abuse in the community. And we heard from paediatricians, we heard from social workers, we heard from mental health teams about children who they were aware had been sexually abused. But of course, it was seen as a criminal matter and dealt with by imprisonment of parents and so on, and was not seen as part of the spectrum of abuse, physical and emotional abuse and neglect. And then it became included as a part of sexual abuse. And of course, what then happened was that people, social services folk got in touch and they said, "Arnon, you sent me this form about children who'd been sexually abused that we'd seen in our patch. So you must be interested in it. Would you see this child for us? Because we're quite worried about them."
You asked for some trouble.
And so we actually set up and established a sexual abuse treatment and assessment program in the 80s, 70s and 80s at Great Ormond Street, and had sets of groups for younger children, middle-aged children, teenagers, parents, even groups for parents who were abusive. So we really began to develop a holistic approach to working with sexual abuse.
So this was the first in the UK, presumably?
Yes, it was, yes. In parallel with the sort of work that the NSPCC had established in working with parents and really trying to help parents and understand processes, particularly, and this is such an important issue, particularly the intergenerational elements, because the whole issue, the whole cycle of abuse that parents had experienced themselves in children or as young people, traumatic impacts that had not been processed, which then came into their parenting. So they became identified with the parental figures who'd abused them and began to see their children's defiant, difficult behavior as deserving punishment, or even beginning to perceive emotional response as sexual knowingness. So beginning to understand the intergenerational aspects and working with parents on their own experiences. And those were the elements of work that came together. And then most recently, over the last 20 years, with the introduction, I think we became aware about 20 years ago, in the late 90s, that we were focusing far too much on the abusive episode, on the actual physical abuse, the emotional abuse, and that's what we were focusing on, and that we really needed to have a much more holistic approach. And so there was the introduction of the assessment framework, which looked at the needs of the children in the context of the parenting and the family and environmental factors. So we began to say, you need to take a holistic approach. And then with my colleagues at Child and Family Training, which we established in 2000, we began to develop a series of evidence-based approaches to assessment, the home assessment of the environment, which looked at the assessment of parenting and the quality of parenting, the family assessment, which looked at the nature of family relationships and what was harmful and what was not, and also the individual experiences of the child and the parent. In other words, a range of ways of looking at the individual, at parenting, at relationships in the family, to really make a holistic assessment, and then to look at what we know was associated with positive outcomes for intervention and those which were far more concerning. In other words, we began to see what would be a hopeful prognosis for the future care of the child, what was far more doubtful. In other words, parents with serious mental health, addictive personality problems that would be much more difficult to be amenable to therapeutic work. We would say those children really needed alternative care. And I was involved with a team that looked at factors which justified the termination of parental access, so other factors which related to establishment of adoption, and other alternative needs of children and parents.
Sorry to interrupt you, Arnon, but to set it in the chronology, the Children Act was 1989.
Yes.
And that framework, the triangle framework, was what anyone who was involved in care proceedings, we got very used to that, didn't we? And that was something that was, everyone knew about it, and it was part of care proceedings when experts got involved in looking at children and what was the best outcome for a child.
But the idea of piecing it all together is a slow process, wasn't it? I mean, my own little experience of the process was in the 1980s when I realised that personality disorders were linked to experiences in childhood.
Yes.
Because, the teaching for adult psychiatrists was simply that personality disorders appeared in your clinic and you tried to do something about it. But there was no idea that it was linked to actually specific events or a pattern of events in childhood. And it was only when you asked that you discovered that people had been sexually abused or neglected, or otherwise you simply dealt with it as a problem behaviour which had to be in some way handled. So it kind of leaked into adult psychiatry rather slowly late on, after you were all busy with what you were doing.
Yes, it's interesting because, of course, 20 years ago we established the assessment framework, which became used widely because it took a holistic view. And then at the same time, Vincent Felitti described adverse childhood experiences and this very large-scale study in the west coast of America, Kaiser Permanente study, which demonstrated that the more adverse childhood experiences the individual had been exposed to, the more likely they were to have adult mental health, physical health, and a shortness of life. Aging of chromosomes and a very powerful impact on the whole of their neurobiological and of course with the triggering of a wide variety of mental health problems. And I think the important issue with talking with this concept of adverse childhood experiences was that what Vincent Felitti did was to say, yes, emotional abuse, physical abuse, sexual abuse, neglect, exposure to violence between parents, which were the recognized forms of maltreatment, those 5, that we needed to look at the context, household dysfunction, mental health problems of parents, interpersonal violence, domestic violence of parents, incarceration of parents, community violence, neglect, and of course the whole issues of poor care and the whole issue of unemployment, welfare. In other words, what Vincent Felitti did was to introduce a very broad-based approach to childhood, to harmful childhood experiences which had traumatic impacts.
One of the problems there, Arnon, is that you get a pushback against some of these developments because people have been reluctant to recognise how widespread these problems are and how severely damaging they are. And you get a resistance to the idea that we should be fussing about these kinds of issues. I say it ironically. It's much easier to deal with a fractured skull or a broken bone and think, well, that's something you have to do something about. But I've sat in waiting rooms in court and heard barristers describing how, if anybody came to look at their house, they'd be just as shocked as they are by the situation they hear about in a client's house. In other words, they minimise the experience of children because it's very hard to accept that it's so widespread and severe.
Yes, I think that's right. And of course, it's taken the pandemic to demonstrate that issues of deprivation, of housing, of poor basic health, of nutritional failure, of unemployment, welfare, the pressure of welfare contexts, and the whole of the context of disparity in the population. I think it's taken the pandemic to say that the pandemic has very different impacts depending on these background factors. So I think that the pandemic has brought into focus that actually stressful events such as a pandemic, and therefore all the other stressful issues, the adversity of childhood, has a very marked impact, and there are a multitude of factors, and that we have to intervene not just with the broken bone, but we have to look at primary prevention. We have to look at parenting for all. We have to look at the availability of welfare, as well, of course, as a focus on the particular concern of a child being harmed here and now, or a child exposed to domestic violence. But without taking a broad brush view of all the factors, we're putting sticking plaster on. We're not actually addressing the main issue.
So one of the problems is this business of deciding at what point you can't work with a family, and that children do have to be moved into alternative care. And how do you think about that when you come to see a family? How do you... What are the factors that make you decide that this isn't going to work with these parents?
Sure. Well, I think we take... we have a staged... with me and myself and my colleagues, Child and Family Training, and previously at Great Ormond Street and the Institute of Child Health, we've taken a staged approach to an assessment. So that 7 stages actually.
Yeah.
The first stage is obviously to know, is somebody's life at risk here and now? Do we have to have an immediate protective action? And for example, in the field of domestic violence, is there life and danger or risk to life and limb? Is on a stage level of risk? Are we dealing with a very high risk situation that a child's going to be harmed? And we have to take immediate protective action. The second stage is a comprehensive assessment. And I think that what we would be advocating, and it would be because domestic violence, conflict in the home is one form of childhood adversity, we have to take a broad view of the context. In other words, we have to have an assessment of the parents' own health experiences. We have to look at the chronology of events in the family over the years in terms of the experience of the child. We have to have a full assessment of the child themselves and of the family relationships, and look at the family in the wider context of support from the community and wider family. In other words, we have to take a broad view of assessment. We then have to use the assessment framework, the triangle, to try to have a holistic description of the needs of the children, how are they being met, of the parenting and the family context. And we have to say, what are the dynamics? What links it all together? What are the factors that are making this couple have such a high level of conflict, or that this particular child is being picked out and is seen as an appropriate individual for punishment, deserving punishment, or neglect. We then have to say, what's the prospect for working with this family? And then we've used the research base on outcomes by having a categories of that we're hopeful because parents are acknowledging that there's a real problem here, there's a concern and they need help, or the child themselves has a very significant degree of anxiety, depression, or traumatic responses and needs help in their own right, that the family has high levels of conflict, and that there's some acknowledgement and awareness of a need to change and a potential for change. So that we regard that as a hopeful prognosis. Then at the other end, when there are factors of very serious long-term mental health problems that are not going to be amenable to short-term or medium-term therapeutic work, where there's very little acknowledgement of responsibility, where everybody else is to blame, not them. They're not acknowledging that the child has a problem. In other words, where you see a very poor response to working with professionals. We see that as a poor prognosis. Where we spend most of our time is in the middle, doubtful. And that's where we say we need to move to another level, our level 6, where we say, let's put together an intervention program to test whether this family can demonstrate they can be hopeful and care appropriately for the children, that they can respond to an offer of therapeutic work, or whether in fact we, having established goals with the family and with the professionals and with the network of what we want to achieve, maybe with the court, and then be able to say, have we achieved those goals? And then we can say, well, we're actually hopeful, or where the prognosis is very poor. And this is where the work that we've been doing recently comes in, because we've been aware that there's a wide range of ways of trying to help families who are responsible for harm or adversity to children because of conflict, or because of mental health, or because of relationship problems, or intergenerational problems, or a whole set of issues. And we've been aware that it's very problematic for practitioners to be able to put together a therapeutic approach, because which approaches do they use? A dynamic approach, systemic approaches, do you use CBT? And so, together with colleagues at UCLA, Bruce Chorpita, we've followed his ideas, which is to say, there are practice elements that all of us, as experienced practitioners, whatever our orientations, actually do that's effective in helping parents deal with conflict between themselves, or helping parents understand harmful processes which children are caught up in. And so we've seen there are practice elements constructing a trauma narrative with an individual to deal with their experiences.
Just turn that into English, actually, Arnon. A trauma narrative is what?
Your story. My story, your story, our story of what happened to us, the harmful events. In other words, the story that we witness, that we hear every day when people talk about their experiences. This extraordinary program of Ian Wright, the footballer, who talked about the program about his experiences, extraordinary experiences growing up, and look at resilience factors. What was it that enabled him to emerge through this? So we've said there are practice elements which we could distill from across the field of intervention, and so that using this model of a modular approach, we've put together a set of guides working with abusive parenting, promoting good quality care, promoting positive attachment, promoting positive family relationships, working with children's emotional and traumatic responses, working with sexual abuse, working with challenging behaviour. So what we've tried to do is to produce a set of guides which are accessible at all levels, to the inexperienced, to the support worker, to social work, to health professionals, people working in the offending field, and said, look, here are a set of resources with step-by-step approaches to intervention.
And it
make a difference.
Were you saying each of those areas is a module?
Each of those areas is a guide with a series of modules within it to deliver an evidence-based approach.
Yes, and is it happening? Because I mean, I know we're mainly involved in discussing things that are going on in the private family courts
at the moment.
Not so much the public law, where there can be a much more sophisticated intervention because the problems are generally more severe. But we're hearing of assessments done over the telephone in 20-minute conversations, children being met maybe once, if at all, and assessments which seem to be pretty superficial and rushed, even though some of the problems the children are facing are really very grave, and you have to question why social services aren't involved in some of these families. So there's a gap somewhere, but you're saying it is being taken up.
Well, I think it's a slow process, but I think there's a concept currently which has been developed in Scotland and in Wales of what's described as trauma-informed care, and which says that the whole network of practitioners, of professionals, of agencies need to be aware that the core basis of problems that trigger serious mental health problems, that serious behavioral problems, is associated with traumatic responses to the whole breadth of adversity, and that therefore, if there's a concern about a child because of a separation, because of parental conflict, because of parental domestic violence, that situation deserves the same approach, a holistic assessment to try to understand the origins. I mean, so much of the research, for example, on domestic violence indicates that both fathers and mothers, both perpetrators and mothers, often have very similar experiences of abuse and neglect themselves. Very high levels within perpetrators, and also within the mothers of children who are abused. So,
and there are some women who are perpetrators as well, who come from their own traumatized background.
And triggering. So, but without a trauma-informed approach to assessment, to management, to professional work and relationships, I mean, it's interesting in the training that we're doing currently with healthcare conferences. We've had interest in the concept of both the modular approach to assessment, to intervention, and our broad-based approach to assessment, our staged approach to assessment, to analysis, and to intervention. In fact, I had a paediatrician came on one of the courses and said, "It sounds to me as though in my part of London we should be setting up a trauma-informed hub so that we can really try to unite and link together all those practitioners and all those contexts which are likely to be associated with traumatic experiences." And I feel that in private law cases, we should be having the same approach to an assessment. Doesn't have to be enormous. It doesn't have to be, I mean, interestingly, we have a very powerful tool developed by Bradley and Caldwell, the home assessment of the environment, which is an assessment of the quality of parenting that the parent offers the child. And it's an interview in the home with the parents and the child. It takes an hour, and within that hour, one can, by interviewing the parent and the child together, within an hour, you can get a strongly evidence-based approach which tells you what the quality of parenting is here. So there are tools which can be carried out without this taking enormous hours. I mean, we've all seen assessments taking place over hours and hours and hours and pages and pages and without it being as effective as a good evidence-based approach to looking at parenting, to looking at relationships, to looking at family relationships. There are tools which can be trained and at many levels and for practitioners across the field of health, social care, education, and social care that practitioners can be trained in assessment and intervention without it being a tremendously lengthy procedure. It's possible. And I would love to see it far more widely adopted.
Just stepping backwards, the trauma-informed intervention, is that encapsulated in ordinary language as asking people what happened to you rather than what you did? Because we're hearing people making that comment that is instead of focusing on what you did, look at where it came from, what happened to you. Is that how we should think about it?
Absolutely. Yeah. What happened to you? I think it's interesting. One event which stands out in my mind very powerfully was that I carried out a serious case review on a child who'd been very seriously harmed by a family member, and this individual had attended probation groups because of other sorts of offending behaviour. And I said, and after having done a full assessment of the whole background, and his background was really pretty horrendous in terms of his experiences growing up, extreme abuse and neglect himself. And I said to the probation team, "What about this history? Do you work with that?" And they said, "No, actually, all the clients we have got the same history, and we focus on what they're doing." Exactly the point you make. We're focusing on why did you do that? Why did you do this harm? Why did you steal? Why did you offend? Not what happened to you. So I think this distinction between an approach which finds out what happened to you as well as what you did, you can't, and how does what happened to you lead to what you did?
Yes, of course. And one of the things we've been hearing about is the domestic abuse perpetrator programs that the courts currently favour, because they're the ones accredited by Respect, which has a kind of monopoly, as far as I can understand it, on accrediting DAP courses, as they're called. And the focus there seems to be on the behaviour and how are you just going to stop doing what you did, whereas alternative approaches to domestic abuse perpetrator programs, which aren't on the whole accredited by Respect, do tend to focus on the life story of the individual and where this behaviour has emerged from. In other words, the experiences. So there's some educating to be done in the institutions which are controlling what resources are available.
I agree with that, George, because basically, if taking our approach of what is the key practice element from across the field, one would say that those two elements need to be put together. That we need both to use the practice elements of understanding the origins of abusive and violent behaviour and the evidence of what works to actually help find alternative to violence, to use cognitive behavioural and cognitive approaches to thinking differently, which of course come into a lot of the prevention programmes. But I think it needs both and.
Yes, and how about
I agree with you.
How about the ideology that domestic abuse perpetrated by men is really an expression of the patriarchy asserting itself over women, and that's the way to understand it fundamentally, and is the approach that
what they call the Duluth model.
Can I just toss that one out at you? And do you get that much in your? Yeah, I always make the point during training that it's our patriarchal context that has a very important influence on male and female gender roles, stereotypes, and so on. But I think that's the background factor. The other element which comes through is the research which indicates that these perpetrators often enough have backgrounds of models of very much violence against women, of violence, of assertion, of power assertive approaches, that they're very much part of a dynamic which may have a basis in patriarchy, but is actually made manifest by what actually happened.
Yeah, they have their own experiences, which have shaped them. Yes.
Yeah. Exactly.
It's not just society as a whole has created this problem.
So there isn't. Arnon, what about this idea that seems to be about in private law proceedings as well, which is, well, we really don't need to spend a lot of time on the history. I mean, I know the answer, obviously, but do tell us, how important is someone's history to understanding what you can do to help them?
I don't see how one can possibly make an adequate assessment of a current context where there's an issue of separation, divorce, high levels of conflict, violence, without looking at the history. And I think it's just this is the same response as the probation team who said all the people we work with have got the same history, so we ignore it.
Yeah, I think you're right. It's a similar approach. We know all these stories. You know, that it's said in the family. We know all these stories, so we're just working on that basis.
I think that's just a fabulous summary of how things have developed over the decades, Arnon. And I mean, you've got the programs which you're training people in. And you're finding that some local authorities and other agencies are adopting them? Because that would be very encouraging.
Yes, there are agencies and there are authorities. And interestingly enough, our material has been translated. And with my colleagues, I did a series of of Zoom conferences in Russia on working with domestic violence, because they have terrible problems there because of changes of the law.
Yes.
So we did a series of programs and have all our material has been translated into Russian, working with charitable agencies, and so we've worked with colleagues there. We've had all our material translated into Arabic, so we're beginning to work with the Middle East. My colleagues, Jenny Gray and Stephen Pitsey, who are part of our team. Jenny was advisor to the Department of Education on child protection, and Stephen worked with me at Great Ormond Street. They teaching regularly in Mexico, material trained in Spanish, regular sessions, and we have a program of giving a workshop, giving the idea about a particular issue, such as working with children's traumatic emotional experiences, and we have a workshop, and then we have coaching sessions where people will go out and work with children and young people, and will come back and have further work to help them put those into practice. So Spanish, Moldavian into Romanian, Russian, Arabic. So we're really beginning to train both in the UK and more broadly, and it's very exciting when people really get it, when they see, yes, this could make a difference.
Yes, it's very encouraging.
There's a mass of people who don't have access to these wonderful things that can help them. They're people with litigants in person, families that are struggling, but they also are very good at looking for advice on the internet. They're very used to using technology. Is any of what you're producing available for ordinary people to access, and would it be able to help them, do you think, if they just couldn't get a service themselves?
Well, I think that's a very interesting and a very good question. I think the material we use has been shared with parents, so there is material that parents could actually use and access. And if people look on our website, Child and Family Training, there's a lot of information about the material, and they can have a look for themselves to see, well, what of this sort of material might be helpful for us, and hopefully with advice and support locally. From practitioners, doesn't have to be at the highest level, but even welfare support teams could be very helpful, because the material is written very accessibly, stages that people could really look at. So point taken that there needs to be a lot more help available online.
Yes.
That's good.
Well, Arnon, we will put those links on the YouTube publication when it's there, so that people can follow up those links and actually teach themselves. And I think listening to you will give people encouragement and hope, but also having a chance to look at that material may give them a way forward and give them an idea of which direction they should be going in.
Can I be very cheeky, Arnon, and ask you if you... Is it possible for you to do a short talk on a different day for us, where the target audience would be families unable to get help? Do you think it would be possible for you to condense into half an hour some advice that might really help people who are struggling?
Yeah. Look, let me give it a bit of thought. I'll need to plan it and to think it through. Of course. So if we could plan a time, then I'd be happy to put together something.
That would be marvellous, because I think people would so benefit from your insights. Yes.
Thank you very much, Arnon.
Okay.
Thank you for the time you've just given us.
It's been wonderful. Really enjoyed it.
Thanks.